Let's come again to these pockets, which we see here. That's a pocket, remember please, it is depression in the posterior wall. Much more usually, inside of the pocket, we can see accumulation of the liquids, pathological liquids. Less usually, we can formation of internal hernias inside of these pockets. Where is located the pockets? Now, what we need attention to, two pockets located in the level of flexura duodenal. This is ascending port of duodenum, and you can see for the flexura we come to jejunum. This is plica duodenal, otherwise the trace ligament. Exactly in the level of the plica, you can see first depression. We call it FOSSA duodenal superior, otherwise recessus duodenal superior. Both names is used. FOSSA depression, recessus pocket. Second depression located approximately 1.5 to 2 centimeters below plica duodenal. And this is the place which is mentioned in the passage of inferior horizontal part of the duodenum into ascending duodenum. In this level also on the peritoneum there are depression. We call it fossa duodenal inferior or recessus duodenal inferior. Let's remember please, in the place of flexura duodenal we have two recessus. Superior in the level of plica duodenal and inferior a little bit below it. Well, let's continue. Another two fossas located in the level of iliocecal angle. Again, look attentively here. Here also we have the fold, which we call plica iliocecalis. Above this plica, above the ilium, we have the first pocket, we call recessus ilio. Look what I say. Plica superior. Second depression located below ilium in the level of the plica, we call it recessus iliocecalis inferior. Why? First one we call iliopolica superior. Second we call iliocecalis inferior. Polica and cecalis differ from each other. It is showing your knowledge of anatomy, guys. Zero. Why this pocket we call iliopolic, this pocket we call iliocecal. I can put zero for everything. Because level of iliocecal junction, this level, measure the border between sepum and colon. Above this level, you have colon. Let's say this pocket called iliopolic, because it is ascending colon. Below this level, we have ciput. Let's say we call it iliocecal. Let's say remember, please, iliocecal. Much more better it is visible in this picture, yeah? Iliocecal, located between ileus and sepum. Iliopolic, located between ileus and colon. This is ascending colon. And border between them, it is iliocecal angle. Above iliocecal angle, we don't have ciput, we have colon. Below iliocecal angle, we have the ciput, not the colon. Remember about it. Let's say once again, this is the third and fourth our pockets. That's an iliocecal inferior and iliopolic superior. Now let's come to this region. What do you see here? The cupula of the cipum with the appendix. As I say you, look please here how the peritoneum covered it from all the sides without mesentery. Without mesentery. Let's say, then you take this cipum and little bit move it to in front. Behind of it you see depression, which we call retrocecal recessus. Recessus retrocecalis. Very important pocket for the surgeons. Why? Now imagine that this is my sickle. Normally, my appendix, by the way, I don't have it because it's removed, but normally my appendix should have such kind of direction. We call it pelvic position. Appendix directed from up to down, from laterally to medially, and finally it is come to the level of linea terminalis. By linea terminalis, it can descend into down or no. But this is normal position. Unfortunately, we have an atypical positions. Why unfortunately? You will spend a lot of time and you will use a lot of different techniques to find appendix. For example, appendix can be hook-shaped and can be directed behind of the sickle. We call it retrocecal position of appendix. Huge problem. If I don't mistake, I spoke about it. One of my teachers, very famous surgeon, Huber, academic, he said that appendectomy in the same time, it is most simple and hardest surgery. Why? If there are typical positions, no any problem. During 10 minutes, you can finish the surgery. If there are atypical positions, you can spend more than 2-3 hours, and even after this have huge amount of complications. Because all appendix is not visible. What will do the stupid person who don't study my subject? He will take just the base and will try to move the appendix. 100% of damaging of appendix, and appendectomy will come to formation of peritonitis. Because content of appendix will flow into the peritoneum, will give the inflammation. Peritonitis, guys, it is primary mortal situation. What does it mean? Primary mortal. Your immunity system cannot stop it and cannot treat it. It can be treated only by emergency, surgical, and therapeutical treatment. Your organism can treat, for example, influenza, can treat a lot of infections, can treat your wounds, if it is not so big, but not peritonitis. 100% of the cases, peritonitis without emergency treatment finish mortally. Remember it forever. And even in case of the surgical and therapeutical treatment, till now, 30-35% of peritonitis, mainly spreaded, finish mortally. So you understand this damaging of the appendix, what will do. Here you will do special type of appendectomy. Look, then you see all appendix. You start to disconnect the appendix from its mesentery from tip to base. Because all appendix is visible. Appendix have the mesentery, cecum no. Mesentery of appendix connected appendix with the cecum. Something like this. If it is cecum, this is appendix, and this is mesentery of appendix. Inside of mesentery of appendix, I have appendicular artery, which is supplying. That's why I start to ligate the artery from the tip to the base. I put arterial forceps and cut this ligament from the tip to base. If I have something like this, atypical position, I have sickle, I have base of appendix, but I don't see the tip of it. Here situation is another. First, I must to cut appendix at its base, and I must to cut now the ligament from base to tip, step by step, and God knows where I will find finally tip of appendix. It can be behind of sacrum, it can be in retroperitoneal space. Even I see once in my life situation of so-called intramural appendix, appendix located under the serous membrane of the cecal. Of course, genetical malformation, yeah. Because I often I don't find generally appendix. No appendix. It is used, you understand? So it confuses you. You see the cecal, no appendix. Finally, what we find is little bit irritation of the serous membrane, inflammation, red color. And we understand that under of it, maybe we make small incision, we apply the micro hooks, open the serous membrane, and under of it exactly we see this inflamed appendix. By the way, 100% of the persons with such kind of position have appendicitis because appendix is pressed by serous membrane. It is pressed and it is destroyed the vascularization. And during the time it gives the inflammational process. But let's again come to our topic and let's continue. Now I described for you 5 pockets till now. Let's make a revision. 2 in the flexura duodenioidalis, 2 in the iliacotic junction, and one behind of the cecal. Now we come to the last sixth pocket, which we call intersigmoid. How we can find it? To answer in this question, again, I will open for you this picture. Now imagine that I inserted my finger inside of the left canal, inside of the left, in the place where the sigma from horizontal become to descending and become to rectal. Yeah? This is place. Exactly in this place, in left to its mesentery, there are the pocket. And this pocket open inside of the left canal. And this pocket we call intersigmoid pocket. Now completely, I give you two sinuses, I give you two canals, and I give you 6 pockets. Remember, please, and attract your attention to the last slides of our picture, about which I spoke before, but let's refresh our knowledge. This is inferior floor of our peritoneal cavity. What does it mean? Now imagine that this is your table, this is the pelvic bones. In real case, they all surrounded this room from all the sides, yeah, because they forms the pelvic girdle, which is necessary for formation of connection between your lower extremity and between your trunk. Yeah, upper extremities have the shoulder girdle, lower extremities have the pelvic girdle. Now this is the pelvic bones. Now imagine that from my roof the sac is come to down. And this sac will be the peritoneal cavity. It is formed by parietal peta. This sac will be continuous up to the level of my floor. My floor will be the level of linea terminalis. Part of this sac, which is located in the level of the table, will be called greater pelvis. False, vice versa. Greater pelvis we call false pelvis. And in reality, it is part of the peritoneal cavity.
So how we can call the muscle base of our peritoneal cavity? Cavern muscle?
How we can call muscles, which is covered.
Cavern muscle?
Which is covered pelvis.
Yes, in the base.
Pelvis from inside covered by iliopsoas muscle, psoas major, psoas minor, musculus piriformis, musculus obturatorius externus and internus. So this all musculus perineus profundus, musculus perineus superficialis. So why you want to call them cavernosus? I don't know.
There's a muscle in the base.
Huh?
There's a muscle in the base to cover the peritoneal cavity.
In the base we have two muscles. Posteriorly located musculus levator ani, which is lift downwards. Anteriorly located musculus transversus perineum profundus. Both these muscles forms two diaphragms. Levator ani forms the pelvic diaphragm. Musculus pelvis perineum profundus form urogenital diaphragm. What does it mean? In the floor of your pelvis, like my two hands, we have two diaphragms. Anteriorly urogenital, posteriorly pelvic. Pelvic diaphragm perforated by your rectum. And it forms the anal aperture. Urogenital diaphragm for females has two perforation, anteriorly located urethral, posteriorly vaginal. For the males, just one. Let's say this one is called urogenital diaphragm because urinal or genital structures perforated. This one we call pelvic diaphragm because rectum perforated. This is two muscles. We will study it. We will study the pelvis in the future. Now I want to attract your attention into another question. Asa, no, say.
Sorry, about the last topic. What is the function of this pocket?
Function of pockets.
Application.
These pockets which I explained.
Yes.
You means what is the physiological function of these pockets? Friends, everything is simple. Look here, please. We must to have special pressure inside of the peritoneal cavity to normal digestive function. From outside of the intestinal walls, we must to have some positive pressure. For example, in your pleural cavity, we have negative pressure. That's why all these enlargements of peritoneal cavity, pockets also enlargement. It is made some special level of the pressure, which is necessary to press digestive tract for normal digestive functions. Only this is the function of it. It doesn't have physiology. It is made some special pressure inside of the peritoneal cavity. Like the small punches, resonators, which is decreased little. If the space is enlarged, pressure is little decreased. Vice versa. When the space decreases, the pressure is
balance the pressure.
if it is closed space. And our peritoneal cavity, especially for the males. Yeah. For the females, I say that by uteral tubes it is great communication, but of course it's not so wide communication. Generally, it is also not widely communicated space. The small amount of, for example, half of the milliliter of the air which can come here doesn't anyhow change this pressure so much. Because you understand what is the diameter of these tubes, nothing. And these tubes is filled by the special type of the epithelium, yeah, that is not so much open.
But why in the bursa mentalis it doesn't have any pocket? Because it is communication with the...
In bursa mentalis you have space. Behind of stomach, look. Hansajan, this is what I said you before. Stomach must to have pressure, and from in front and from behind. Otherwise, functional specificities of stomach will be impossible. Let's say behind, if the stomach will be, for example, touched with backside to the retroperitoneal structures, enlargement and constriction of the stomach will stand impossible. Let's say evolutionally, for example, my table is stomach, and in front of it and behind of it, we must to have free space. You understand what is the problem? This is, and unfortunately, friends, Hamza can ask not only about physiological, but of course much more about pathophysiological. But because what is our level to speak about ideas of the God? Yeah, we can just only try to understand. Yeah, what is the meaning of this? But generally, we should come to the conclusion that everything in our body has some meaning. We don't have any structure without meaning. Other question today: I understand this meaning or no? This is connected with the level of the knowledge, the level of the science. Of course, during the time, science tried to understand, first of all, physiological specificities, to come to conclusion about pathological specificities. But believe me, it's much more to understand the pathology than physiology. Let's say pathophysiology, generally, it is much more simple subject than normal physiology. Much more, because pathological situation is visible. It is detectable. It is understandable. Sorry, if your stomach is perforated, these pathological conditions you can see and understand. But to understand hard physiological normal mechanism, why it's necessary to have bursa mentalis behind of the stomach, for example, it is not so simple. You must have much more clever and much more developed brain to understand it. To understand that if the stomach will be perforated, content will come to outside, it's not necessary to have so high level. Do you understand me? But pathophysiologically, this space which is behind of stomach is very dangerous. Because if I will compare, for example, ulcer of anterior wall with ulcer of posterior wall, or even tumor of anterior wall and tumor of posterior wall, I will see that posterior wall structures, it is so-called blunt structures, asymptomatical structures, not so much painful structures. If the posterior wall ulcer will be perforated, after many days only, patient will come. And usually what will say the patient? Some pain in the back, like in case of, for example, rheumatism, or for example, radiculite, or for example, in case of some small hernias, intervertebral. Usually what we'll do to drink some anti-inflammatory medicines or symptomatic to decrease the pain. Paracetamol. Before the problem will come to Winslow, before Winslow it will come, or before the problem will kill the patient. What will be the cause of the killing? If the ulcer perforated to backside, look here please, he is behind of me pancreas and stomach. We see a huge complication of the ulcer which is called penetration. Don't mix it with perforation. Perforation, it is opening of aperture. Penetration, it is growing of ulcer from one organ to another. If ulcer will penetrate the pancreas, it will make the autolysis of the pancreas. We call it acute pancreatitis, necrotizating pancreatitis. Necrotization of the pancreas kills us, you know what? It is increased the ferments 1,000 times inside of the blood. Instead to go to digestive tract, ferments, lipase, amylase, protease goes inside of the blood and destroy everything. Make the lysis of all blood elements, all the structures, all the vessels. This is aggressive structures. Why we need to have activation of these ferments inside of digestive tract? If they will be activated inside of pancreas, they will eat the pancreas. They will make digestion of it. That's why I say you, in case of the reflux of the bile, inside of the pancreas, it gives the acute pancreatitis. Most usual case of acute pancreatitis. That's why guys, by your religions or by some taboos, if it is forbidden to drink alcohol, it is not so simple. Because alcohol, what it made, it is irritated papilla duodenum major. During the time it is decreased the size of it. And your bile cannot normally outflow inside of the duodenum. Why it is mainly the problem of alcoholics who drink the alcohol? Because it is irritating the mucous membrane. Then the mucous membrane is irritated, finally, what we see? Sclerotization. Same is happening in the case of the gallstones, bile stones. Stone can come to papilla duodenum major and can also obstruct it. Sorry, what will do the bile? Bile must flow in some place. Instead come to outside, it will come to pancreatic duct. Let's say, friends, if you go to have normal logical thinking in the medicine, you must to have the base. I say it many times. Without base of anatomy, it's impossible to speak about topography. Without base of topography, it's impossible to speak about surgery. Without base of surgery, it is impossible to work in the medicine, generally. This is why I say you anytime, work every day. For example, very clever person, but how he worked? From exam to exam. He started to study before examination. And I say him many times about it. And this made big problems for him. He knows that he have good memory. It is maybe not so hard, but the more quick you study, the more quick you forget. And this is just the general cheating for whom you study. If you study just to show for your parents good mark, okay, this is one situation. If you study to receive good knowledge for the future, to be prominent doctor, this is another situation. So remember about it, guys. This is simple.
I will start to say.
You must do it yesterday. Yesterday. I told you many times, forget about future. Then you say, I will, you make cheating. I will, it is impossible. I can do it now, or I cannot do it everywhere, every time. Forget about will. The will, doesn't work. Again, attract your attention here. What about I want to speak here? These depressions has huge therapeutical surgical importance. We can detect pathological conditions inside of them, and there are special methods. It is method of investigation or per rectum or per vagina. What does it mean? For example, females have the extrauteral, for example, pregnancy, which gives the tubule, for example, which gives the bleeding, internal intraperitoneal bleeding. Where will be accumulated blood? In Douglas space. If you will insert your finger in the vagina, you will see prolapse of the posterior wall. Prolapse. Instead, smooth posterior wall, you will have something like this.
Semicircle.
Your finger will come and touch, and you will feel dilatation, liquid movement. Little bit you push, your finger descended to, because wave is formed. Waves. You understand? What can you do? Simply by the needle, you can make the puncturing, you can take the liquid to it. Is it pus? Is it the blood? Is it the lymph? Is it the serous liquid? I don't know. You must take it for cytological investigation. Otherwise, we call it serological investigation. Remember, please. Okay, let's continue. For the males, same I can do from the anus. For example, most useful method for detection of the enlargement of the prostate gland. Where is your prostate gland? This is the prostate gland. It is located between your urethra, urinary bladder and rectum. It is surrounding the middle portion of your urethra. And here we have relational apertures by which the ductus deferens come, perforating the urethra and open the secret of it inside of the urethra. Sperma come by this ductus deferens and enter inside of the urethra. What is the main oncological problem of the males? Yes, of course, prostatical cancer. Now, from one of our staff persons, father have this kind of oncological problem, awful situation from the prostate. First of all, problem is spreading into the rectum, exactly contactogenously. Then hematogenously from the rectum, it is spreading to the stomach. Awful situation. Of course, you understand that in such kind of the spreading cancers, we must make just only palliative treatment. I cannot, remove all the organs of the peritoneum. It is impossible.
Chemotherapy.
Or radiotherapy, or for example, very good is word here, internal beam radiotherapy. What does it mean? Source of radiation, you insert it inside of the rectum, and from short distance, it is influenced into the prostate and kill. Because external radiotherapy is much more side effect.
Yes.
Because you make the radiation of the big portions of the human body, and it gives, of course, a lot of the side effects. Internal beam radiotherapy, in another hand, it is less traumatical because you maximally inserted the source of radiation near the locus of the crime. In the future, we will speak about it, but generally remember, guys, if local tumors you can surgically remove, spreading tumors usually not. Let's say that, oncology generally have the 4 branches. Yeah, it is the surgical oncology, chemotherapeutical, radiotherapeutical, and target. Here also we included, for example, the hormonal therapy, bone marrow, stem cells, transplant. But anyhow, surgery works only with local tumors. Surgery doesn't work with the metastatic tumors. Only one exception we have. If there are, for example, metastatic tumors, which is CRES, neighboring located important structures, here you can make palliative surgery. For example, resect part of this tumor to decrease the pressure. Very bad method, you know why? Because then you resected part of the tumor, you open the vessels and make possible hematogenous metastasis of the tumors.
Yes.
You damage it. But anyhow, if it is cranial cavity, if it is CRES, important structures, for example, I make the compressive trephination, but it's not enough. In that case, of course, I will cut and remove part of the tumor to reduce little bit pressure. Unfortunately, chance of the metastasis will be increased. How many minutes I have? Approximately 10 minutes. Let's come to the next topic. Write the name of the topic, please. It is the